All right, let's begin. Domestic violence or sexual assault. The thing is, first of all, for violence, domestic violence, what do you think? Who is gonna be your patient? Meaning, usually, who are the victims of domestic violence? I would say anybody can be the victim, isn't it? But mostly, you will see extreme of ages. What I mean by extreme of ages, you will see, for example, an elderly patient. You might see a child as a victim of abuse. You might see a female, or you might see mentally disabled, challenged people, right, as the victim of domestic violence. But yes, otherwise, I can say anybody can be the victim, but usually these are the main ones. Yeah. Domestic violence, it is a very, very sensitive topic. It's very sensitive topic. So you have to be very careful when you start the consultation. The patients, the victim, they're not going to open up that easily. They're not going to open up that easily because they have to have that safe environment. So you have to build the rapport first. Then only you need to jump to the domestic violence topic. Yeah. They don't know who are you, right? So you need to build that rapport. You need to build that relationship first. And then once it's done, then maybe you can start talking about the domestic violence issues. And then you will see they might be able to share the information with you. But if you start from minute one and poking them on the problems they might be facing at home, they may not open up to you because they're not very comfortable with you, right? And see, we know, like in the exam, it is scripted. It is scripted. So what we need to do is we need to build the rapport first, and then we will be coming to the domestic violence topic properly. Yeah, that's the thing that I want you to do. In all the stations, I usually say keep an eye on these 4 points as well. What are these 4 points? Number one is voice control. So make sure you are very soft spoken. So this is really important. You have to be soft spoken. Your tone of your voice is going to do wonders in ethics and specifically these stations, domestic violence. Yeah. So be very careful on that. Eye contact. You have to give proper eye contact. You will see the patient might not be giving you proper eye contact. Patient might be looking here and there. Patient might be looking down. These things can happen. But what you have to do, you make sure you keep looking at the patient because you will see these patients going to give you lots and lots of non-verbal cues. Yeah. So what you need to do is simply just acknowledge those non-verbal cues. That will be your task. Yeah. Fine. So voice control. So make sure you are soft spoken. Eye contact. So make sure you properly give eye contact to your patient. That's really important. Nodding. Sometime when you see when patients when they started talking, what you need to do, make sure you're doing nodding. That's really important. Yeah. Okay. Yeah. Nodding. So if patient is talking a lot, what you do, you have to nod your head so that you give them active signs of listening as well. Keep distance, very, very important this point for this domestic violence. We say it's your patient. Sometimes what happens is when the patient is shouting, what they do, they come close to you. What you need to do, you need to go a bit back on your seat. Yeah, that's what we do. Now, in these kinds of scenario, like domestic violence, abuse scenario, where patient is not opening up, what you need to do, so patient is sitting, maybe looking down, not giving you eye contact. Obviously, you're trying with your voice. You are having very soft voice, or soft spoken, and you're trying your best. You're reassuring the patient, you're giving confidentiality, everything you have done. But I want you to do something with your posture as well, with your body language as well. What you can do, it's it's your patient. What you do, you just go a bit close to them. Just try that. So, for example, if I'm sitting like this, I'll just go a bit close to my patient. These are the non-verbal things that you have to do in the exam, and you will see the examiner will be sitting somewhere nearby, and they will acknowledge. They will see these subtle changes in your posture, and you will see the patient is going to open up early. The patient is gonna give the information to you very quickly, right? Some of us will be saying like, no, the patient didn't open up to me. Patient gave the information in after 5 minutes, 6 minutes. But others are saying, no, the patient was very nice with me and they gave me the information after 3 minutes only. What is the difference? The difference is how you talk to the patient, right? They're not biased with anybody. It's about how we actually manage them. Yeah, so this is really important. In these scenarios, you will see you will have lots of verbal, but lots of non-verbal cues as well. So that's really important. And make sure we are not missing on these non-verbal cues. Comfort the patient, that's your priority. So always make sure you show that. And you keep telling the patient that you are our priority. Acknowledge their emotions. Whenever you see they are not comfortable, you will see these patients might be looking down, they are not giving you eye contact. Some are very shaky, they're shaking their leg, they're shaking their hands as well, right? And while talking, they're not very clear with their talks, they are mumbling and all. So you will see lots of non-verbal cues, and what you are supposed to do when you get these non-verbal cues, you need to acknowledge. I can see you're not comfortable. I can see you are worried. I can see you are anxious. So use one of it. I'm not saying say all these three things, but yeah, use one, two of them. Give a bit more time to this patient to open up. Yeah. Patient safety. Again, you will see this word, patient safety, this phrase in almost all my slides. What I mean by that, assess the patient's current condition. So see, a patient has come to you. They're not going to tell you straight away that I'm the victim of domestic violence. Sometimes what happens is they will book an appointment saying something else. For example, they might say, Doctor, I'm not able to sleep. That is their presenting complaint. But to be honest, the presenting complaint is not they're not able to sleep. The problem is domestic violence. They are the victim. Somebody is abusing them, but they can't tell you that straight away. So what they will do, they will fake something sometimes. They'll have some presenting complaint. We have a station patient might be saying, Doctor, I've got bleeding from vagina. But when we examined, there was no bleeding. But the thing is, these patient has to book the appointment and they don't feel comfortable while booking the appointment saying, I'm the victim of abuse. Nobody's going to say that. So what they do, they will have a presenting complaint. So what I want you to do when you are in these kinds of station, talk a bit about that presenting complaint as well. And that is going to be very helpful in building the rapport as well. Right. For example, the patient has said that, Doctor, I've got problem in sleeping. I can't sleep. And you understood patient is not able to sleep, then why the patient is showing you lots of non-verbal cue? There is something wrong. So what you did, you acknowledge the emotion and then you started talking a bit about insomnia as well. Like, where is the problem? Do you have problem in going to the sleep? Do you have problem in maintaining the sleep? At what time you go to bed? At what time you go to sleep? At what time you wake up? Do you wake up in between? So asking some of the question to build the rapport. There's another case where patient is pregnant and she's saying, I've got bleeding from my vagina. But examination says there is no bleeding. What do? You go and ask, okay, I can see from the notes you're pregnant. That's good. And how far you are in your pregnancy? Is it your first pregnancy? You said you had bleeding. How much bleeding was there? I mean, just ask these 4 or 5 questions about the current situation of the patient. That's what I mean by this phrase, patient safety, or assessing the patient's current conditions. That's really, really, really important. Yeah. So do not jump to the topic straight away. What do, you take a bit of history in regards to the presenting complaint of the patient. Yeah, that's what I mean by it. So comfort your patient that you are our priority. Acknowledge their emotion. Acknowledge. This is something that I can't stress enough. I mean, this is the most important thing. Whatever you see, you have to say it. Whatever you see, you have to say it. Then only you will have good score in your exam. Yeah. Patient safety, do not jump to the topic straight away. What you do, you just take a bit of history about the current situation of your patient. Yeah. Give them time, give them confidence. Yeah. So the thing is, do not bombard these patients with the question. No, you need to give them time. You need to give them confidence as well. I'll show you some scripts, then it's going to be very easy for you. Give them time, give them confidence. You don't need to put up with all these things. What is happening with you, it's not right. We can help you, we can support you. But for me to help you, you need to help me first. You need to tell me what's been happening. Trust me, you are my priority. So say all these things. And when you are giving confidence to somebody, you have to make sure your voice has confidence as well. I've seen sometimes some of the doctors, they're telling it to the patient that, yeah, I can help you. The voice, that the way you're talking, it doesn't feel like you can help me. I would say help yourself first before helping me out, isn't it? Isn't it? So you have to be very careful. Your voice should have that confidence. That's really important as well. Yeah. Confidentiality. See, the thing is, GMC says you do not need to offer confidentiality straight away. So don't offer confidentiality straight away. But yes, the thing is, If you feel patient is not opening up, if you feel that yes, patient is lying to me, then what you can do, you can definitely offer confidentiality as well, right? So do not offer it in the beginning. Sometimes it is written, sometimes it is kind of very clear in the question that it is a domestic violence topic. So don't do this thing that you enter into the cubicle and the straight away you have offered confidentiality. Don't do that. Don't do that. So what you do is start talking to the patient, you make them comfortable, take a bit of history, and then you feel like no, patient is not opening up. He or she is hiding something. Then what you do, then maybe you can offer confidentiality. Whenever you offer confidentiality, what you need to do is you need to say the discussion will remain confidential between you and the team, between you and the team until everyone is safe. Be very careful. I have seen some candidates, they say the conversation will be between you and me. That is wrong. It's not going to be between you and the patient. It's going to be between the patient and the team, right? So it's going to be between you and the team. And why I've written this until everyone is safe. You have to be very careful. See, there are many instances where you might have to breach the confidentiality as well. When we breach the confidentiality, when it is not safe for the patient, when it is not safe for anybody. So when there is a threat to the patient or to anybody else, we might have to breach the confidentiality as well. And we make sure we as a doctor, we are transparent, we are honest. So we're not lying to the patient. So if you tell the patient that the conversation is going to be between you and the team, and sometimes in the end you feel like there is a threat to the life of this patient and you might be breaching the confidentiality. And then what your patient is going to say, no, you said it's going to be between you and the team. Why are you telling them? Why are you involving them? I don't want you to involve them. So it feels like you're lying to the patient. So what I want you to do in the exam, in real life as well, the discussion will remain confidential between you and the team, between you and the team until everyone is safe. So mention this point, until everyone is safe. So that's really, really important. Now, what I want you to do is whenever you get the domestic violence topic, I want you to ask specific domestic violence questions as well. So we have got these domestic violence questions. HARK question, we say, HARK, HARK question. Because violence is not only physical violence, it could be emotional violence, it could be sexual violence as well. So H is what? Humiliation. A is afraid. R is rape. And K is kick. So you can ask these hard questions as well. So what is humiliation? How I'm going to ask humiliation? If you feel like what? Humiliation. If your partner is making you feel bad about yourself. If your partner is making you feel bad about yourself, that's humiliation. Are you afraid of your partner? If he is forcing you for any kind of sexual activity when you don't want, that's rape. Kick. If he's abusing you physically, that's kick. So in this, if you see, we are covering emotional, physical, sexual violence, everything. So you can ask these hard questions. Now, what I feel, asking these hard questions straight away might be a bit harsh as well. And I always believe that you have to go very subtle way. You have to do these stations in a very subtle manner. So before asking these hard questions, I would like you to go with some general questionnaire. What are these general questionnaires? So you have comforted the patient, you have taken a bit of history as well, you have acknowledged lots of non-verbal cues. You know this patient is not opening up, patient is looking down, shaky patient. You have mentioned with the patient that we are here to help. You're trying to give confidence to this patient. You have given confidentiality as well, but this patient is not opening up. Now the point is that there is something happening and we need to find out. So, what you do is start with general question. Before you jump into the domestic violence hard question, I want you to start with general questionnaire. What will be these general questionnaire like? So, whom you are living with? Who are you living with? I'm living with my partner. Okay. How is your relationship? Is everything all right at home? See, lot of answers you won't get from these patients. They won't say anything, but still you will get the answer. For example, how's your relationship? My answer is Is everything all right at home? So with the body language, you'll get a lot of answers. So this is really important. Keep giving pauses, keep asking these questions, but don't bombard the patient with questions as well. Whom you are living with, how's your relationship, is everything all right at home? Are you getting along well with your partner? Do you have arguments with each other? Are you afraid of your partner? So what I mean by that, start with these general questionnaire. So you're offering confidentiality and then start with these things. When you feel there are lots of non-verbal cues in the scenario, whom you are living, how's your relationship, is everything all right at home? Are you getting along well with your partner? Do you have arguments with your partner? Are you afraid of your partner? Again, don't bombard the patient with the questions. So what do you do? With the posture also you're trying. What you do, you're just coming a bit close to the patient as well, asking one question, then wait, asking another question, then wait, then offering confidentiality, asking another question, offering confidentiality again with enough pauses. When you do these things, see that 2-3 minutes of the station is going to give you tough time. So first 2 to 3 minutes you spend in building the rapport, and then 2 to 3 minutes will go in doing these things only to make this patient open up. They're not going to open up straight away. They will take your time. They are checking your patient's level as well to see how much patient you are, because patient is not opening up. So are you going to give up or are you going to try a bit more? Try a bit more. Patient will open up. So start with these general questionnaire. Patient will open up. If not, go with heart questionnaire as well, right? And eventually, what is going to happen? Patient is going to open up. So now, when patient has opened up, what you need to do now? You have to plan the treatment as well. So, for example, if I say your patient is the victim of abuse, do you think it is safe for this patient to go back to the same house? Not really, because this time, okay, patient was fine, but patient might not be fortunate the next time. So she might be in more trouble the next time. So now, when she has opened up, now the plan is you need to make a treatment plan. So what can the treatment plan? So I would like you to take detailed social history as well. What I mean by the social history here. Social history. See, now we know it is not safe for this patient to go home. Yeah. So I would like you to take more social history. Like, who else is there in the family? Do you have your parents, your brother, your sister, any other relative nearby? Because this patient is going through a very tough time. Obviously, we as a medical team, we can involve our social services and arrange a suitable accommodation for this patient. That's absolutely okay. But still, I want you to ask social history as well, because if this patient is going to stay with the family, if the patient has got family support, that is much, much better. So now you are actually trying to make the treatment plan. What is the management plan, I would say? So take a bit more social history. Who else is there in the family? Any brother, sister, parents living nearby? That's really important. Now, pregnancy, children, what I mean by that. In the UK, your children is government's kid first, and then it's your kid. So when you are dealing with these domestic violence topics, so for example, there's a female, she's the victim of abuse. If she's the victim of abuse, if there is anybody else, if there is any child at home, if there is any elderly person at home, can they be the victim of abuse as well? The answer is yes. So you are not only managing this female patient, you are managing everybody else at home as well. So that's what I mean by that. Social history, who else is there in the family and all for the support system. Plus, ask if she's pregnant, if there is a child at home. That's very important. If there is a child at home, and if he is the biological father of this pregnancy, if he's the biological father of the kid at home, if he's abusing you in front of the child, right? So these questions are very important. Right, so these are the most important stage questions. Partner, you can ask if he's doing it under the influence of alcohol, if he's doing it under the influence of drugs, if he's having any mental health issues, right? If he's having any criminal record. You can ask these questions as well. I know you might be thinking it's too much, but you can ask these questions. Yeah. So social history, take a bit more history, asking about the pregnancy, children, any elderly person at home, because if this female is a victim of abuse, the others can also be the victim of abuse as well. And I would like you to be very careful on that part. Yeah, so that's what you do. Now, how to offer help. So what happened is in the UK, what happened is in all the hospital we have got a designated person who can put you in contact with the organization. The name of the organization is MARAC. What is it? It's Multi-Agency Risk Assessment Conference. Multi-Agency Risk Assessment Conference. So multi-agency, there are lots of agencies under them. There are 15 to 20 agencies under them which can help the patient out in everything she wants, right? So what you have to say, we have a designated person in the hospital. I'll put you in contact with that person. That person can put you in contact with lots of organization and will help you in everything. That's it. So now if the patient says, how will I look after the education of my kids? The organization can help you in that. I'm not working, how I'm going to manage my finances? The organization will help you in that. I don't have any place to stay. The organization will help you in arranging a suitable accommodation. I'm afraid of my partner. The organization can involve the police as well. So, I mean, whatever she needs, accordingly, we can offer her the managements, right? Don't just start with, I can help you with education, finance, accommodation. No. Maybe she doesn't need your help with accommodation. She might be living in her house. She might be needing your help with the police. So first ask what kind of help she wants, she needs, and then accordingly you're gonna offer. Now, do I need to remember the name of these agencies and all? Not really. Not really. So simply say we have got a designated person in the hospital who can put you in contact with the relevant authorities. That's enough. Otherwise, MARAC is multi-agency risk assessment conference. Right? So that's gonna be your treatment plan. Sometimes you will see that patient might say that I have to go home. I don't want to stay here because from today, if she takes your management plan by, I mean, involving police and staying in different accommodation and all those things, her life is gonna be completely different. Completely, you're changing her life. So she might not be okay with that. So she might still say, no, I have to go home. I'll come tomorrow and I'll see what can be done. The thing is, make sure you keep her in the hospital because if there is anybody else at home, if there is any child at home, any elderly person at home, so you have to involve social services. You have to involve MARAC. Social service is also under MARAC. So you have to involve the relevant authorities because you're not only managing her, the domestic violence victim, you are managing everybody at home as well. So that's really important. You can tell the patient and do the nice counseling that, say, for example, Maria, I mean, I would say you're fine now. It's fortunate. I'm glad to know that you're fine. So, but if you go home now, you might not be fortunate the next time. There might be some problem with you, with your kids, isn't it? So it's advisable you stay here and get the treatment what we are offering. And if she still says no, that's not going to happen. If she still says no, please involve your senior and finish it off. Because as an FY2, I don't think so you'll be making that final decision. You definitely want somebody, some senior to be in the picture, right? That's what you need to do. Another thing is thank her. Whenever the patient opens up in the station, thank the patient. Thank you for opening up. I know what you've been going through is really difficult, but now you have opened up to me. You have discussed it with me. I'll do my best to help you out. You're not alone. We are here to help you. So say all those positive things as well, and make sure your voice has got confidence as well. Right? So this is something that you need to do when you get a station on domestic abuse. All right. So what we do like comfort the patient. You are our priority. Acknowledge their emotions. That's really important. Patient safety. That is very important. Take a bit of history. When you take a bit of history, what happens is it is gonna be helpful in building the rapport as well. I don't want you to jump to the domestic violence topic straight away. Yeah. So give them time, give them confidence. Your voice should have confidence as well. Right. And the confidentiality if needed. Do not offer confidentiality in the beginning of the station, but you can do it in the later part when you feel patient is not opening up, patient is lying to you. You can offer confidentiality as well, saying the discussion will remain confidential between you and the team until everyone is safe. Yeah, and then you can ask a hard question as well. But if you feel that the hard question is a bit harsh, so what can I do? If you feel they are harsh, what you can do, you can start with some general questionnaire as well. So what you can ask, whom you are living with, how's your relationship? Is everything all right at home? Are you getting along well with your partner? Do you have arguments with each other? Are you afraid of him? Right? So these are the things that you can do, right? And keep acknowledging nonverbal cues as well. When she open up, you can ask hard questionnaire as well. Humiliation, if your partner is making you feel bad about yourself. Afraid, are you afraid of your partner? Rape, if he's forcing you for any kind of sexual activity when you don't want. Kick, if he's abusing you physically. Right? So these are the things, you can do. Yeah. So these are the things that can be done. Now, what you need to do once she has opened up, you need to plan the treatment plan. So take a bit more social history because it might not be a good idea to send the patient home. So you need to see where I can send this patient. Obviously, social services, we can arrange the accommodation, but it will be good if she stays with her family members and also ask if there's anybody else in the family, your parents, your brother, your sister, your relatives nearby. Ask about who else is there in the family, pregnancy, children, that's really important as well. If she's pregnant and if he's the biological father, if he's abusing in front of your child, how's his relationship with the child? All those questions are very important, yeah? And partner, if he's doing it under the influence of alcohol, under the influence of drugs, if he's having mental health issues, all those questions you can ask, right? And thank her for opening up. That is really, really important as well. And do not underestimate the power of distance as well. So what you need to do when you are seeing like she's not opening up, what you do, just go a bit close to this patient as well, right? I'm not saying take your chair and go very close to her. No, you will be invading the personal space of the patient as well. Just a subtle change in your posture would be quite helpful, right? So that is something that you can do. Now, the problem is sometimes you'll see the patient might open up a bit late. For example, just take an example. Patient opened up that something is happening at my home and she opened up at 6 minutes. Now you know you're left with only 2 minutes, and it's very difficult for me to ask all these questions, like asking about social history, asking about pregnancy, children, partner, and then Marak and all. It's gonna take time. It's gonna take time. Now, if you are in this situation that only lasts 1.5 or 1 minute left, everybody else is gonna be in the same situation. I know you want to do a lot of things. I know you want to ask so many questions before you do the management and all. But if you don't have time, what you need to do? So if you want to do simple thing, if you want to ask or if you want to do 10 things in the management, but you have got the time that you can only do 3 to 4 things. So what you do, choose what is the most important thing I have got that I definitely had to do. Let's go with that. For example, last 1 minute left and I haven't offered the treatment plan. Patient has just opened up to me. Now, if I go in detailing of social history, pregnancy, children, and partner information, I can't offer her help. Help is we have got a person, a designated person who can put you in contact with the relevant authorities and we can help you and support you in everything. That's your treatment, isn't it? And then patient might have some concern. Patient might say, no, you have to counsel the patient. It might take like a minute or 1.5 to 2 minutes. So you should have that much of time. So the moral of the story, if you feel you're having less time, you don't have enough time, and last 1 minute left, please offer help, please offer support. Don't think that I'll lose some marks. No, you will get lots and lots of marks. You will get full marks, no problem at all. Because it's not only happening with you, it's happening with everybody. They're checking your patience level as well. But now when you're left with 1 to 2 minutes, do not ask so many questions. Please close the station by offering the management plan as well. So that is your domestic violence. Yeah. So do not forget confidentiality, when to offer. Do not miss the patient safety part. Take a bit of history, build the rapport first, then only you will go for it. Yeah. Then keep distance. You might have to go a bit closer to this patient. Yeah. Hard question might be a bit harsh. So start with some general question here first. And please have an idea about the time management. Do not just keep on asking question. Right? So be very careful on that. Patient will open up maybe at 6 minutes bell. So you should have enough time for the management. See what is the most important thing for me in the management, right? I have to be a smart doctor. Intelligent doctor is different thing, but for this exam, you have to be smart to pass these kind of stations. Yeah. So that was domestic violence. Rape and sexual assault. The things are done almost the same way, but there are some different things as well that I'll try to cover in it here. First of all, these station, you always have to have good control on your voice. You have to be soft spoken. I always say females are good in it. Males, you have to maybe practice a bit more. Your voice have to be soft. You have to be soft spoken. Eye contact, make sure you have got proper eye contact with your patient, because you'll get lots of non-verbal cues, and what you will be doing, you will be acknowledging those non-verbal cues. Nodding, if they talk, nod. Keep distance, yes, if they are not opening up, you may have to go a bit close to them as well. So same thing, that is what you have to do. For example, let's take an example. Your patient is saying, I want a sick note. Because again, whenever you have got a scenario on rape or sexual assault, and when they come to you for help, they will not they will not be telling you straight away that I'm the victim of this sexual assault or so. So they might be coming to you with some other problem. So other problem might be one of the time patient might come, doctor, I'm worried about STI. You're worried about STI. Now start talking to this patient. Why are you worried about STI? What exactly is happening and all? And then eventually you will see patient will have lots of non-verbal cue, and they'll tell you the real information to you in the later part of the scenario. Sometimes patient might say, doctor, I just want a sick note. Okay, you want a sick note. I'll give you sick note if that's what is the best option, but I really want to know what happened, why you need a sick note. So whenever patients are asking you these kind of things, you need to cross question them. You need to ask them why, what is the problem, what's the reason behind it, right? So what work you are doing, if there is any problem at work, are you not able to concentrate at work? What exactly is happening? What is the problem? You want a sick note. What's the problem? Right? So why you need a sick note? So these are the things that you need to explore in the beginning. So you got domestic violence topic, you got sexual assault topic. They're not going to open up straight away in the beginning. They're going to take a minute or two. And that's the thing, I want you to build the rapport. So I want a sick note. Why? I just don't feel well. What's the problem? I just don't feel well. But okay. So do you have any chest pain, any shortness of breath, any tummy pain, any diarrhea, any constipation? No, no, no. Okay, what work you're doing? Are you having any problem at work? Are you having any problem in concentrating at work? So ask some questions. Ask some questions. Keep acknowledging the non-verbal cues. Patient is going to give you so many cues, non-verbal cues. Acknowledge, I can see you're not comfortable. I can see you are worried. I can see you are anxious. See, I'm here to help you. I know you want a sick note. I'll give you the sick note if that's the best option. But I really want to understand what's happening, and I really want to help you out. And if you tell me, then only I can help you out in a better way. Say those things, acknowledge. And when you acknowledge, just don't say just one line, say a few lines the way I said, isn't it? Patient will feel more convinced as well. Yeah. So explore the reason, comfort the patient, acknowledge their emotions, patient safety, that's really important. Assess the current situation of the patient, whatever the presenting complaint they have got you in. So just ask a couple of questions for that as well. Give them time, give them confidence, tell them we are here to help you, we are here to support you, right? And confidentiality, if you need to give confidentiality, do not hesitate to give. Do not offer confidentiality in the beginning of the station, but in the later part of the station, if you have to offer confidentiality, that is absolutely, absolutely fine. The discussion will remain confidential between you and the team until everyone is safe. Fine. Now what you do, you go with the social history as well. Who else is there in the family and all? Now, this patient is actually saying, I'm the victim of sexual assault. So what happened is they might be giving you different stories. Let me share one. So for example, this can happen. I don't want to go to my work. I want a sick note. What exactly happened? I just don't feel well. Okay, you don't feel well. What exactly you mean by you don't feel well? What is the problem at work? And then this patient might open up and say, it's just like I don't drive my car anymore. And they start blaming themselves. It's my fault. I don't know why I parked my car there. You're like, what the hell is happening? But when the patient start talking, when the patient becomes comfortable with you, they'll start talking. When they start talking, let them talk. Just make sure you are listening to them carefully. The station is about listening. Obviously, this patient will take time in the beginning to start talking to you, but when they start talking, you do not interrupt. You don't ask for explanation. If somebody is the victim of domestic violence, somebody is a victim of sexual assault, Don't ask them, tell me more. Don't ask for the details. It's not good. Don't ask for details. Don't ask them why you didn't stop when it was happening with you. Don't tell them to forget about what exactly has happened with you. So you have to be very, very careful when you're dealing with these kind of cases. It's not going to be easy, right? But when they start talking, you make sure you let them talk and you listen to them carefully. Yeah. So this patient is like, I parked my car in the parking area and I finished late and I was attacked. I was attacked. I was attacked. Patient keeps on repeating things. I was attacked, and the person was wearing the mask. I couldn't see his face. He just dragged me to the working shed, and I was sexually assaulted there. So these are the things the patient is going to be asking, right? Then uh, we can also ask whether the person was spiked or not. Sometime they might give you a scenario like I was in the party and one of my friend's friend has raped me. So you can ask whether you were spiked or not. What I mean by spiking, whether you've been given any alcohol or drugs before that. So that is what we mean by spiking. So for example, you have got a victim of sexual assault and they came to you. So you can ask whether you were spiked or not. So, what can happen? The person who's done this assault might have put something in the drinks and all. So, too much of alcohol or maybe putting some drugs in the drinks or so. So, that is what we call as spiking. So, whether the victim and the other person who's responsible for the sexual assault, if both are like under the influence of drugs or alcohol, so that can be asked. Now, for sexual assault, we have got this support, SARC, Sexual Assault Referral Center. And in the GP, we do not have all the facilities. We don't have all the facilities. So whenever we get any victim, any patient like that, so what we do is we refer them to SARC center straight away so that they can do the thorough examination. So they can do the medical and forensic examination. We can talk about the emergency contraception as well if you've got a female patient, and we can test the patient for STI as well. That's why I said in the beginning, sometimes the presenting complaint with these patients might be, Doctor, I'm worried about STI. They're like, why are you worried about STI? And when you go in a bit more detail, when you ask more questions and all, this patient will open up later. Yeah. So that's something that you have to do. So in the SARC center, what's going to happen? We'll be testing them for STI as well. So that's what happens. And don't forget to thank these patients. Any domestic violence case or any sexual assault patients, when they open up, thank them. Thank you for opening up. I know what has happened was not right. It was quite unfortunate. But now you've opened up. I'll do my best to help you out. Now, these patients, those are victims of sexual assault, you cannot force them to involve the concerned authorities. You cannot force them to involve the police or so. So remember these points. First of all, supporting a victim of sexual assault, what you can do, you first of all believe what they are saying and tell them that you believe them. That's really, really important. Listen to them, but don't ask for details of the assault and why they didn't stop it. That's the worst thing that you can do in the real life or in the exam as well. Sometimes, you know what happens is whenever we are doing a history station or so, we always say, ask the patient, tell me more about it, tell me more about it. You can't ask these things to these patients. And they will take time to speak as well. For example, if I'm saying I'm the victim of domestic violence or sexual assault, I'll say one line, I'll have lots of non-verbal cue, and then I'll be saying my second, third line as well. I'll be taking time. Once I start talking, once I start feeling comfortable with you, I'll take time in talking. I'm not going to say very quickly all the things. No. What happened was a very tragic incident. So I'll be going slowly, slowly. What you need to do, just listen. That's the thing. Yeah. Offer practical support like going with them to the appointments. The thing is, the patient has come to you, to the GP, you'll be referring them to sexual assault referral center, isn't it? So what you can offer it to them that I can come with you as well because this person has shared lots of information with you, and now you're going to refer it to them to the sexual assault referral center, and he needs to say the same things again to them as well. So you can offer practical support by saying, I can come with you as well and help you in explaining what has happened with you to the other team members as well. Yeah. Respect their decision whether they want to report it or not. You will offer them like it's advisable that you involve the police as well. And if you say, no, I don't want to involve the police, you cannot force them. But respect their decision, but encourage them that it's advisable to involve the police as well. If you want, I can call them on your behalf. But doctor, how it's gonna be helpful? What has happened with me has happened. You cannot change it. You cannot undo what has happened with me. Can you? You're right. I cannot undo what has happened. But if you do this, if you inform the concerned authorities, if you involve the police, it is gonna be very helpful in your healing process as well. You will feel more comfortable. I know what has happened. I can't change it. But it's gonna be helpful for you in the future. It's gonna be helpful in your healing process as well. Yeah, that's something that you can do. Be aware they might not want to be touched. There's a bad touch and a good touch. So what happens is when somebody is the victim of abuse, so what we do sometimes out of like just to show them empathy, we just tap on their shoulder, this and that. Make sure you never touch these patients because they are still in the trauma and they might not want to be touched. So be very careful of that. Don't tell them to forget about it. Be patient and supportive in their healing process. Yeah. Don't tell them, never tell these patients what has happened, just forget. Start your new life. Never say these things. Never say these things. Tell the patient that we are here to support you. We can put you in contact. I can refer you to the SARC center and we can do all these things there. We can test you for STI if that's your concern. And we can do the medical forensic examination as well. All these things are kept confidential as well, right? That's really important because see, when you do the forensic examination, you need to get the samples and all. So the samples has to be taken as soon as possible. If you delay, you will not get what you're really looking for, isn't it? So usually they say the sample has to be taken within 1 week time. It should be taken as soon as possible, but within 1 week time. So even if this patient says, I don't want to report, tell them like, even the thing is, first of all, it's going to be helpful in your healing process. It's advisable you report it. Because if you feel like you don't want to repeat it today, that's fine. You don't want to report. But if, for example, after a week or two, you feel like, no, I want to report, that's fine. You can report, but then we can't get the samples because we have to get it as soon as possible. So what can be done that we can take in the SARC center, we can take your sample now. We can take the samples now and we will store it. We won't process these samples. But in case in future, if you feel like, no, I want to report it and I want it to be processed, then we can do it. So that can be done as well. Obviously, with the patient's consent only. But the sample has to be taken as soon as possible because if you delay it, you won't get what you are looking for. Yeah. So that's what you need to do. So explore the reason why this patient wants a sick note, comfort these patients. So acknowledge their emotions, patient safety, take a bit of history. That's really important. Do not jump to the topic straight away. Please acknowledge their non-verbal cues as well. Give them time, give them confidence. That's really important. And confidentiality if it is required. And when they started opening up, when they're giving you the information, listen to them carefully. Don't ask for details. Whatever they're telling you, that is enough, right? Trust them and never tell them to forget what has happened. Do not touch them as well. Offer them practical support. Offer them that we can come with you to the sexual assault referral center. We can get the sample and we can test you for STI if that's your concern, right? So all these things can be done. And for the history and all, maybe we can ask about social history. Who else is there in the family and all? For the management perspective, it's going to be helpful. And if it was under the influence of drugs or alcohol, so that can be done. And thank them for opening up whenever they give you the information.